Hello, my name is Frank Domino. I'm a family physician and the editor of the 5-Minute Clinical Consult, and welcome to today's session. I'm a community-based family physician that also teaches at the University of Massachusetts Medical School, and I'm thankful for you for joining us today. Also on this session is Dr. Edward Schwartz. I'll have him introduce himself.
Hi, hello everybody. My name is Ed Schwartz. I'm Chief Medical Officer for Care Here, responsible for over 200 health centers, but I also still play real doctor as a family practitioner, filling in some of our health centers, but also working acute care on the weekends. And I'm real excited to share with you how 5-Minute Consult has allowed both myself and my clinicians in the field to be more effective when seeing patients.
I'd like to just talk a bit about how we came to today's 5-Minute Clinical Consult. Back in the late 90s, I served as an associate editor for family medicine at Up to Date. And in 2005, the team from 5-Minute approached me about taking on the editorial role of the 5-Minute Clinical Consult book with a few mission-driven ideas. One was to add in evidence-based medicine to the content, and the other was to make the content of the then book into a user-friendly tool that could be used both in paper and digitally online. With regards to evidence-based medicine, we chose to use the SORT taxonomy to label content, specifically content around diagnosis and treatment, stating what's the best evidence on how to address things. We overhauled all the content, which was a huge task. And this is what you might see in the course of looking something up, a reference, in this case reference 1, followed by bracket A, meaning that this recommendation is based upon systematic review and meta-analysis level data. So how does the 5-Minute fit compared to other digital tools? Well, most people listening know of Up to Date. I worked at Up to Date for 5 years and know it well. It's an expansive database. It has two main drawbacks. One is that it's so big, it's hard to find information quickly. The other is it's rather expensive, and it's written primarily by subspecialists. And so the recommendations you get are often based upon that particular subspecialist's approach to care rather than what we do in the primary care setting. I've also worked with Dynamed. Dynamed's a fantastic evidence-based database that does a very diligent job looking at the best available data on most topics that we see in primary care. The database is most useful for large groups and insurance companies to understand what to cover and what not, and has limited utility in the care of primary care patients in the outpatient setting. And then there's 5-Minute. We've expanded the content dramatically to over 2,000 topics with large numbers of diagnostic and treatment algorithms and videos. The real advantages of the 5-Minute are its ability to find best evidence fast. So let's break down the benefits. As I said, it's entitled 5-Minute, but I bet you can find most answers to your question in under a minute when you're using the digital form of the book. It's very fast, it's very user-friendly, both on the web and on your phone. We try to make it extremely relevant to community-based settings because that's where most of us practice. And we've made it into an excellent teaching tool to help learners at every level understand both anything from the basics of a disease to how it's managed and its prognosis. We've highlighted the evidence-based content, and we've added to our database a very large coverage for both drugs and laboratory tests and interpretations. So within the content, everything's hyperlinked so you can find out information very quickly. As I mentioned earlier, we have a very large database of diagnostic and treatment algorithms and have a huge pool of therapeutic and patient education videos. Our future goals are to hope expanding the content to include different languages and enhance the patient education content. And we've been expanding our video content every year. So let me tell you how I might use it. I was teaching residents one day when a 56-year-old male presented with atraumatic right shoulder pain. And the resident says, oh, he probably got a tear of his rotator cuff, he needs an MRI. And I said, whoa, wait a minute. You need to take a really good history, generate a very solid differential diagnosis, and then do a physical exam, because there are other things that can cause your shoulder to hurt. And he kind of knew the differential for acute atraumatic shoulder pain, but he really felt uncomfortable doing the physical diagnosis that needed to go with it. So I decided to show him how to use the 5-minute, and I'll show it to you in much the same way. Hopefully you can see here the homepage for the 5-minute clinical consult. It's very clean and very straightforward. You can browse, you can search everything from this main search bar here, or you can limit your search based upon what you want. Down on the right are our featured topics, including our COVID-19 topic right here that we update every week. So it contains the best information available. So I wanted to talk to him about how to diagnose shoulder pain. So I decided to take him to the shoulder pain algorithm, and I typed in the word shoulder, and there's a diagnostic algorithm and a treatment algorithm. So let's look at the diagnostic algorithm. He worked down, here's the common causes, and he realized there was no trauma, and he had good passive range of motion. So the pain was localized to the lateral shoulder, and he had a positive empty can test, but he didn't know my resident didn't know what an empty can test was. And I said, oh, okay, that's pretty easy to teach you. And so I took him back to the procedures, and I looked under shoulder. And sure enough, here's a list of all the shoulder videos that we have. Some are procedures and some are physical exam. And so he didn't know about the empty can test, so I showed it to him, and let me show it to you now.
Shoulder exam, empty can test, supraspinatus strength test. The empty can test is performed by bringing the arms into 90 degrees of abduction and 30 degrees of forward flexion. The arms are then internally rotated. The patient resists a downwardly directed force. Pain and/or weakness are considered a positive test.
So he did the empty can test on the patient along with other diagnostic maneuvers, and sure enough, the patient had an impingement syndrome, or what we used to call a rotator cuff tendonitis. And we reviewed the treatment, and the resident had never injected a shoulder. So I said, let me show you how to do a subacromial shoulder injection. It's hyperlinked right here, and I'd love to show you this video.
Shoulder exam, subacromial space injection, posterior approach. The injection site using the posterior lateral approach to the subacromial space is found by identifying the area 1 to 2 centimeters inferior and medial to the posterior lateral corner of the acromion. The syringe is angled towards the acromioclavicular joint with a slight superior lateral angle. This area can be marked by the tip of a closed pen or syringe cover. The area is cleaned by iodine or alcohol prep. Ethyl chloride can be used for superficial anesthesia. The syringe is advanced approximately 1 to 1.5 centimeters towards the acromioclavicular joint in a slight superior lateral direction. There should be no flashback of blood. The injectable solution should flow smoothly into the subacromial space. If resistance is felt, then the syringe should be repositioned.
So it's a very quick and easy tool that's easily hyperlinked and in my mind, helps a great deal in clinical practice. I look things up on 5-minute in front of patients all the time and feel that they appreciate the fact that I'm looking up information in front of them, recognizing that I need a refresher, whether it's what test to order, what drug to start, a drug dose, or how to interpret an outcome. With that, I want to invite my friend Ed to talk about how he uses the 5-minute by describing a slightly different case. Here.
Well, one of the things while we're bringing up those slides is I always remember when I was in training, physicians who were older and teaching always said, you will forget more than you ever learned. And I think that's probably even more important to realize now that when we look at the speed of technology and how fast medicine's moving, you know, I always joke around that as family practitioners, internal medicine, people doing primary care, Anybody who says that they know everything is either delusional or a defendant, or unfortunately sometimes both. And I grew up in the days when we didn't use computers like we do now in medicine, and I also grew up using the textbooks, which were wonderful. But as soon as I got introduced to 5MinuteConsult online, it really opened up doors, because I had used other evidence-based resources, but I found myself getting frustrated because you'd be reading through these articles and you'd hear, well, you can do this, or you can do that, or it depends on this, or use clinical judgment. And there was contradictory information, though very good didactically. When I had that patient in the exam room or waiting for a response, for guidance, I found I couldn't get it timely. I spend my weekends doing acute care. So pulmonary embolism is something that often comes up with that patient that comes in and is short of breath. Frank, can you advance the slide? So this was a case I recall. A resident, I used to teach in a residency program, as a second-year resident, was seeing a female. The patient was 52 years old, so relatively young, was on hormone replacement, had also had some knee surgery. And the patient came in with some leg swelling, complaining of shortness of breath. So this resident was very astute right away, saw the risk factors, and was concerned about a pulmonary embolism. But then had to stop and say, well, what do I do? What are the steps? What are the things I need to rule in and rule out? So I'm going to jump real quickly into the 5-minute consult and kind of just walk you through. So again, just bringing up pulmonary embolism and doing a quick search. That easy. I'm not even going through the different categories. I'm kind of an algorithm person. I find it's very helpful in medicine to kind of walk us through. So I just go right to algorithms, and let's just start off with diagnosis. So again, being able to walk through from the very beginning of clinical signs, is the patient stable? And then really walking through the probability. Sometimes in medicine, we just start ordering tests, but sometimes you got to stop and understand, what's that test going to tell you or not tell you? So again, being able to look at risk factors, really being able to understand how to get that next step. With also the ability to very quickly hyperlink over to the full pulmonary embolism database. But before we do that, I'm going to go back, because once I've decided now that I've done the appropriate workup, sometimes just treatment. I mean, I think of all the medications that have been added. I'll show my age. I mean, I remember when we pretty much just used heparin, and then it became low molecular weight heparin. And now we have all these other medications besides Coumadin that we can use. So which way do I go? So again, having the ability to quickly look at, we got the probability of a PE. Is anticoagulation indicated? Yes or no? And then again, walking down that algorithm. Well, now I'm into the point where there are new medications. I'm not sure I don't know a lot about that medication. And again, if you see it in blue, it's a quick hyperlink. So I can just click on that. It takes me right to the pharmacy page. So again, I can walk through the specifics on that medication, the contraindications, things I need to watch for, dosing. Again, so many things that we need to know, we're trying to get at our hands, and it's impossible to know all this. And at the same time, you want a resource that gets you right there. Well, if we go back, again, let's just go back and just jump into the whole pulmonary embolism side. I now have the ability to walk through, again, basics. Am I thinking right? Am I doing the right things diagnostically, both from a physical exam, looking at the differential diagnosis, as Frank was talking about, and what tests do I need and how do I interpret them? And then looking at treatment. Well, one of the things that always hits me is, and it can be just for pulmonary embolism, it can be for anything. How often do we get that one lab that's abnormal and we go, I don't remember all the causes, all the possibilities? Well, in this case, let's just go right to D-dimer under the lab area. Again, it gives you the definition. It reminds you what it's testing, what it does, how it's used. How do you interpret it? Because again, when we look at D-dimer, there's many other clinical areas that can give you a false positive. And so having that additional data to be able to walk through and understand that, understanding the limitations. And as you can see, there's a whole host of lab tests that you can choose from. Well, my patient now has questions for me. Why, Doc, why are you ordering this test? Again, I can quickly go in, I can pull up my patient handout, and explain why that procedure is done. I can print this out for them. I live in Phoenix, Arizona, so a lot of our population is Spanish speaking primarily, or Spanish speaking only. Being able to quickly click on and flip that over to Spanish speaking again, I've got a resource for the patient. And I'll share, my philosophy why that is so important to have resources, whether it's written material, handouts that we can customize, you can personalize this, whether it's videos that they can watch and then you can discuss afterward. Probably the one thing that I think we don't do as well as we need to do in healthcare to really help our patients is education. And so to have a resource that very quickly is written at that right level for them to understand, have them read that when you step out of the room or while you're in the room, and then be able to make sure that they truly understand what's going on in their body, that really leads to them having more comfort, but it also leads to compliance. And what are we trying to invest as family practitioners, internists, and primary cares to make sure our patients get the best care? Well, if they're not compliant with the treatment, that's simply not going to happen. So this is one of many ways that I use 5-Minute online, 5MinuteConsult online. And again, I really recommend, if you have not used it, that you give it a shot, because I think you'll be as surprised as myself and our whole organization of clinicians on how effective it is in making sure we provide evidence-based medicine, and our patients who trust us always get the best care. With that, Frank, let me turn this back to you.
Ed, thank you. I appreciate that. I just want to conclude with Ed and I are both available. My email address is here. If you have any questions about how to use it, problems you have, or thoughts or suggestions, I love getting emails with any kind of comments and criticisms. The benefit of the tool is that it's very fast. I might want to also add that every search you do is tracked, and if you so wish, every 2 searches equals 1 hour of continuing medical education credit. So not only do you get to use this, you also accrue credit just by looking things up. So please, if you haven't given it a try, please try the online version. If you have any questions or comments, drop me a note. And I again thank you for joining us for this short session on using the 5-Minute Clinical Consult in community-based clinical practice.